I'm delighted to be here at this 10th Einstein University International Clinical Oncology Conference, and I'm extremely happy to be here. I would prefer to be present. I would prefer to be live, but unfortunately I need to do this filming because, because of after ESMO there are a lot of meetings, and unfortunately I cannot make it. But in a way to say thank you to Dr. Mohamed Yassin for his kind invitation, for looking after me, to be there. I'm bringing here to all of you a present that you gave me in 2015, and I'm delighted to have this present. This is in my desk, in my office at home. I am delighted. That was the present that I received in the second meeting from the Einstein University. So I am very happy to be here. Dr. Yassin asked me to talk about how we can do the, let's say, precision medicine in urothelial tumors, but in a sequence, how we can optimize, how we can maximize the treatment options of our patients with metastatic urothelial carcinoma. Let's try to make it. Well, these are my disclosures, and this is what the bladder cancer will look like in 20 years. From 2020 to 2040. Take a look at the forecast of new cancer patients, new bladder cancer patients that we will see in the next 20 years. And take a look at how this disease is exploding. It's exploding, not only because of the many new options that are now. Well, this presentation will be released after ESMO, so we can talk about the new exciting data. The first-line treatment is changing. We have several options in subsequent lines of treatment. So, well, probably if you need to invest in one tumor, this is definitely the tumor you need to invest on. But not only because of the amount of drugs, but because of the number of new patients that will be diagnosed of urothelial carcinoma in the future. Well, take a look at the data that we have in the Asia. Well, almost double, 80% more patients will be diagnosed in 20 years. Well, I am missing here the Middle East region data, but in Africa, well, it is the double, 101% of patients that will increase in the number of diagnoses in this tumor. So definitely, this is a tumor that we need to put an eye on it. This is what the current landscape before ESMO was looking like, and well, we have a standard of care, induction chemo followed by avelumab maintenance, or if the patient is progressing during the induction chemo, well, second line with immunotherapy is considered a standard systemic approach. Enfortumab vedotin, the first antibody drug conjugate, would be considered the third line option, while putting together with erdafitinib, the FGFR inhibitor here, pushing to the fifth line treatment, to the all chemotherapies like taxanes or like influrin in this setting. After ESMO, what do we have? Well, we have different first line treatment options. Probably there is one winner, enfortumab vedotin plus pembrolizumab, but there is still room for chemo upfront followed by avelumab maintenance, and there is still room for cisplatin gemcitabine plus nivolumab in this first line scenario. We need to talk about biomarkers, we need to talk about patient profiling here, we need to talk about access. Well, probably not everybody, not all the countries will be able to afford to pay for all of these new compounds in the first line setting. What we should do after? Well, precision medicine and erdafitinib will become a greater role, will have a greater role in this scenario. Probably, well, it will be mandatory to test molecular viable patients to try to identify those patients with FGFR2, FGFR3 alteration. Erdafitinib would be definitely there. Enfortumab vedotin, if not given before, of course, should be also one of the most important alternatives, and we are looking forward to seeing the data. Probably at the early, in the first half of next year, we will see the data of the TROPiCS-04 trial with a second antibody drug conjugate, sacituzumab govitecan, that may fill this gap in the second, third line treatment with another antibody drug conjugates that have already progressed to enfortumab vedotin in first or in second line setting. Drive or the outline of this talk would be based on these four statements. The first one, the personalization of the systemic treatment in metastatic bladder cancer starts with you in your office, with the clinic of your patients, with the symptoms of the patients, with the patient profile that we have. And don't forget that Galsky was dividing the first-line treatment profile in between two patient profiles, eligible for cisplatin or ineligible for cisplatin. But take a look on the right side of this slide. Those patients that are ineligible for any platinum, even for carboplatin. This is what we call the Gupta criteria. And the Gupta criteria are becoming more and more important, more and more relevant in daily practice. Why is that? It's because we have a clear standard of care. Chemo upfront followed by avelumab maintenance. It was clear before ESMO. After ESMO, well, we still don't have the data. I still cannot share the data with you. But when you listen to this presentation, well, you will be aware of the very good news that we have in this field. By doing that, by doing induction chemo followed by avelumab maintenance for those patients that are responding, we can achieve a median survival of around 30 months. This is true that in the EV302 and in the CheckMate 901 with cisplatin gemcitabine nivo or with enfortumab vedotin pembro, well, the standard control arm didn't reach these 30 months of survival. It was in the range of 15, 16 months in the control arm. Why is that? It's because not all patients that are starting chemotherapy, they reach to the maintenance therapy. On top of that, well, do you remember the third patient profile that I mentioned before? These patients that are not eligible even to receive any platinum, even to receive carboplatin. Well, this is what we can expect, or this is what the real-life data are telling us in different countries across the world. And what you can see in these circles is the percentage of patients that, despite of the diagnosis of this devastating disease, the patients are not receiving any systemic treatment at all. Of course, access to drugs can be an issue, of course, maybe, mostly in the US. But patient willing, the patient empowerment is also important because patients can be afraid of the toxicity related to the chemotherapy that we have. And if the patient wants not to be treated, well, this is an issue, clearly. What can we do for those patients in this third subgroup? Those patients that cannot even tolerate or they are not eligible to carboplatin. Well, this is to my knowledge, the only prospective randomized trial with an immuno-oncology drug, durvalumab, a PD-L1 inhibitor in this scenario, patients ineligible for any platinum. And as you can see, well, what we can really expect from immunotherapy is very small, only 4 months of median progression-free survival. And you don't see any long-lasting responders or very good outcome in the long-term setting. We have one drug approved in this scenario according to the FDA, pembrolizumab. This is the labeling of pembrolizumab according to FDA for patients in first line ineligible for any platinum. The problem here is that the FDA labeling of pembrolizumab is not telling us how to define these patients ineligible for any platinum. I think what I am doing in my practice to use the common sense. And when I have a patient in front of me, well, I say, okay, this guy is, can afford to, for at least carboplatin. The toxicity is gonna, make me, is gonna threat the patient in this setting. Well, I don't know. We still need for a clear definition of what is a patient ineligible for any platinum. This is the design of the DISCUS trial. And with the DISCUS trial, we try to minimize the number of cycles of chemotherapy as induction we are giving before avelumab. What we want to see on this trial is if 3 cycles of induction chemotherapy are not worse in terms of overall survival versus 6 cycles followed by avelumab maintenance, but with a better tolerability, with a better quality of life by reducing the number of cycles of chemotherapy we have to give before avelumab maintenance. What about the second topic? Personalization of systemic treatments that depends on the access. Once again, you can see this wonderful slide in which you can see how many options our patients may have. However, I don't know what is going to happen in Egypt, but at least in Spain, a country like Spain cannot afford to pay all patients with metastatic urothelial carcinoma to receive all of these drugs. At all. So we need to think twice about that, because we have very active tools to give in a subsequent lines of treatment those patients that are progressing to chemotherapy, platinum-based chemotherapy, and immunotherapy. Well, you have the options to give them enfortumab vedotin, the first antibody drug conjugates to be approved according to the EV301 trial. Enfortumab vedotin is better in terms of survival than former chemotherapy that we were using, taxanes or vinflunine. We have also the opportunity to give personalized treatment, erdafitinib, an FGFR inhibitor in patients with FGFR2 or FGFR3 altered tumors is better than all chemotherapy in this scenario. And we have also the option to give sacituzumab govitecan that is approved by FDA, not yet by EMA, but well, we have the options to sequence these new strategies. Okay, the thing is, well, the activity is not bad. Take a look at the partial responses that we can see in around 40% of the patients for erdafitinib and for enfortumab. I think these drugs are very potent to rescue patients that are progressing to platinum and immunotherapy. I think sacituzumab govitecan maybe is less potent, but probably the tolerability is better, or at least neutropenia and diarrhea can be better managed in our hands than neurotoxicity or skin rash that enfortumab may offer, or the pneumonitis or mucositis or hand and foot syndrome or diarrhea or problems in the eyes that the new FGFR inhibitors can be given. So we can play with these drugs. However, the thing is, can we really afford to pay that? And can the patients afford to pay in terms of the adverse events that these new compounds are given? Well, this is something that with the more experience that we have, probably we will try to solve in the future. The third statement, ideal personalization of systemic treatment is based on biomarkers. Do we have biomarkers in patients with metastatic urothelial carcinoma? Well, we have some biomarkers, or at least promising biomarkers. I don't know if they are yet ready to be used in daily practice. I'm afraid the use of these biomarkers is a little bit far to be used in daily practice. The first one is Nectin-4. Nectin-4 is the target for enfortumab vedotin. Don't forget that this antibody drug conjugate is targeting the urothelial cells because the urothelial cells are expressing Nectin-4 on their membrane, on their cell membrane, and it has a payload of a kind of taxanes that gets inside the cell. Okay, where, in which tissues Nectin-4 is expressed? Well, take a look on the right. In the extreme right, you can see that the skin is the tissue with the highest expression of Nectin-4, and this is the main responsible of the toxicity induced by enfortumab in this field. But take a look at the expression of Nectin-4 in urothelial cells, the other cancer cells, and also in esophagus. So probably these two tumors are the more promising tumors according to the expression of Nectin-4 to be used in enfortumab vedotin. The expression of Nectin-4 is a positive prognosis. It's a good prognostic factor for patients. So probably immunotherapy will work better in patients with Nectin-4 positive, and chemotherapy will work better in patients with Nectin-4 positive. Well, if you believe that a personalized treatment is driven because of FGFR2 and 3, probably you're right, these patients have another option, erdafitinib, and definitely FGFR2 and 3 is the best biomarker that we have so far in this scenario. However, enfortumab vedotin activity is exactly the same regardless the expression or the alteration in the expression of FGFR2 and FGFR3. No difference in the activity we can expect of when given enfortumab in patients with FGFR2 or 3 alterations. That means that enfortumab vedotin is better or worse than erdafitinib in this setting. We cannot say that. They have not been compared head to head, but if you cannot have access to an AGS testing to identify those patients with FGFR alterations in your daily practice, don't be afraid, don't be worried, because enfortumab vedotin will respond. What are we gonna do in the future? In the future, we have at least 3 antibody drug conjugates in phase 3 trials that are supposed to come to the first line or to the second line treatment. Nectin-4 with enfortumab vedotin, TROP2 with sacituzumab govitecan, and we have also an antibody drug conjugate called the zitamab vedotin targeting HER2. They share with enfortumab the vedotin, the payload, so the same payload, the same chemotherapy for these 2 different targets antibody drug conjugates, Nectin-4 and HER2. Take a look at the level of expression that you can see on the left of Nectin-4, TROP2 and HER2. Well, probably HER2 is selecting only for around 30% of the patients that are positive or they have amplification of the HER2 transmembrane receptor. We can target urothelial cells by these novel antibody-drug conjugates. The expression of TROP2 of Nectin-4 is almost universal in the majority of the patients in this scenario. In the future, can we identify the best patient for each of these antibody-drug conjugates? Let's see. To complicate a little bit more the landscape of the biomarkers that we have in this setting, take a look at this German retrospective work that they did comparing the expression of Nectin-4 on the primary tumor versus the metastasis. And these German guys, well, they saw that there was a different expression in the primary tumor versus the metastasis, and there was a loss in the expression of Nectin-4 in the metastasis of the urothelial cancer, particularly bladder cancer. Do you think that this loss in the expression of Nectin-4 was conditioning for the activity of enfortumab? Well, you can see that in the red curve, in the Kaplan-Meier curve, you can see that the survival of patients with lower Nectin-4 expression in the metastasis, well, they didn't show any significant benefit to enfortumab in this scenario. However, those patients that you can see in blue, with the high expression of Nectin-4 in the metastasis, in the tissue from the metastasis, from the rebiopsy of the metastasis, they have the better survival. Should we perform rebiopsies of those lesions that are growing to try to see the activity that we can expect from enfortumab in this setting? Well, I don't really know. But what I know is that probably if we want to have a good biomarker for the enfortumab activity, probably instead of going to the tissue coming from the primary tumor in the bladder, well, probably we should go to the metastasis. And probably the metastasis tissue is more informative in terms of biomarker than the primary tumor itself. And what about the expression of Nectin-4 according to the different histology variants that we have? Well, take a look at this. I think this is very graphic. Well, the activity that we can foresee when we are giving enfortumab vedotin to other histologies different than urothelial tumors can be completely different. Probably I wouldn't offer for enfortumab vedotin to patients with sarcoma-treated tumors, because the expression of Nectin-4 is very small. However, in squamous or plasmocytoid tumors, I'm quite convinced that enfortumab vedotin can play a good role. So definitely, we may have a biomarker. And what about functional imaging? Well, in PET-CT scan, we can measure the expression of Nectin-4 in the tumors. Do you think there is a correlation in between the expression of Nectin-4 with this gallium N188 versus the standard glucose PET scan? Well, there are some lesions that can express both of them, Nectin-4 and glucose, but there are some other lesions that may express only Nectin-4 and not glucose, or only glucose and no Nectin-4. Probably in the future, the functional imaging by PET scan may help us and may drive our treatment decisions in the future. Well, let's see. Definitely, we need prospective data and randomized data in this area. And finally, what am I doing in my daily practice? How I am doing the sequence in my patients in daily practice? Well, I am following the ESMO guidelines. We still don't have access to enfortumab vedotin pembro. The data has just been released. We still don't have access to cisplatin gemcitabine nivolumab. The data has just been released. So what we have today is chemo induction followed by avelumab maintenance. Or we have chemo induction, but patients are progressing during the chemo induction, second patient profile. And we may have also 10, maybe 20% of the patients that are eligible to single-agent immuno-oncology drug, pembro, or Atezo in the first line. So depending on what you give to your patient in the first line setting, I am doing something in the sequential treatment. And don't forget about this slide, because I think it is important. Metastatic urothelial carcinoma is a devastating disease with an extremely poor prognosis. Take a look at the deterioration of the performance status that is conditioning that only half of the patients, at least in the US, are receiving systemic treatment, probably because of the poor performance status. But of this percentage of patients that are receiving treatment, only 1/3 will be receiving second-line treatment, and only 6% of the total amount of patients will be receiving third-line treatment. I think these data are scary. But take a look at the graph that we have when giving avelumab in the maintenance therapy. Well, if you don't offer avelumab, well, 60% of the patients will be progressing in the first CT scan despite of an initial good clinical benefit to the induction chemo. But despite of using avelumab, 40% of the patients in the first CT scan will be progressing. So we need more drugs and better drugs in the subsequent lines of setting. We need drugs that can rescue patients from the progression in the second line setting. Enfortumab vedotin, according to the ESMO guidelines, is the most recommended treatment option that we may have here. And the data coming from the daily life are telling us that what we saw in the EV301 trial with enfortumab single agent is what you can expect in daily practice in your patients. What can we give to the patients that are progressing during induction chemo? So you give cisgen or carbogen to your patient, and the patient, after 2, 3, 4 cycles of chemo, they are progressing. Well, this is the worst scenario, the worst prognosis patients are there. Well, according to the ESMO guidelines, you should give pembrolizumab in this setting, according to the keynote of 45. And this is right, you are impacting the survivor. However, I'm not clear to do that in my daily practice. In fact, how many patients do you think are really reaching the avelumab maintenance? Because they are not that much. Daily life data and the InVigor 130 data are telling us that only 30 to 40% of the patients that are starting chemo are finally getting immunotherapy as a maintenance. This is an issue in daily practice. What can we do to those patients that are progressing during chemo, 65 years old? You give cisplatin gemcitabine, and the patient has pleural effusion, liver metastasis, and huge primary tumor progression. Do you think pembrolizumab, single agent immunotherapy, is going to rescue these patients? I don't really think that. I think a drug like enfortumab, a potent drug like enfortumab, can rescue these kind of patients. And this is what we have in the EV101 trial, phase 2 single arm trial in patients who did not receive, in the red columns, chemotherapy before. And finally, what can we give to those patients that are progressing to single-agent immuno-oncology drugs? Well, the response is coming from the EV201 trial, cohort 2, patients with only one single-agent PD-1 or PD-L1 inhibitor. Take a look at the magnitude of the benefit. More than 80% of the patients were responding to enfortumab vedotin, so I don't have any doubt enfortumab vedotin should be given. This is my almost last slide. And take a look at the scenario, the clinical scenario, the readout times of the phase 3 trial in this setting. Well, forget about the metastatic urothelial carcinoma, we have a lot of options. The new trials are coming in the muscle invasive and in the non-muscle invasive setting. Our colleagues, our team work together, oncologists, urologists will be a role. We need to work together, we need to enforce our work together here. A lot of trials are coming. Thank you so much, and I would be happy to answer all the questions, but unfortunately, I cannot be able to make it live. Thank you so much, and I hope you can forgive me. Thank you.